So how do we treat them? Conservative measures, I think I just gave that one away. Endoscopic treatments, shockwave lithotripsy, open surgery, dissolving, we talked about that, laparoscopic and robotic, depending if that's what you guys do. A lot of times your choice is made dependent on the position of the stone. You know, years ago choice was really, you know, based on position of the stone. Now our guys will go all the way up into the kidney with ureteroscopes and laser stones. So the limitations aren't there anymore. Again, different positions, different stones. Stones don't have to be very big to cause a whole lot of hurt, right? You know, this is a little tiny thing here. I mean, it's obviously magnified, but those are millimeters. The chief treatment that we try to utilize is something to get the kidney unblocked, because it's not the stone that hurts, it's the blockage of urine. So if you can stent it, get a tube in here from the kidney to the bladder to allow urine to get around it, they'll be pretty much pain-free. Why pretty much? Because now they got a stent in their bladder, which is going to cause urine, the reflux, and cause pain when they urinate. We got a stent that's going to cause their bladder to want to fire off, and they'll have frequency. So they'll be irritative instead of, you know, an agony. Most people would prefer to be irritated. Conservative measures such as observation. If it's a small enough stone, we always tell patients, if it's small enough, you can pass it. If it's not causing a fever, that's the only time it's really emergent to do something, because people get septic if they've got blockage and a fever. And pain tolerance. If they can tolerate it, you know, they can kind of sit on it and try to pass it. And I think if I never had a stone, but I think I would try conservative measures myself. But the alpha blockers, big change. I mean, a lot of the stones we used to have to go after, 5-6 millimeter stones, you know, dose of tamsulosin, and they're bringing it in a cup for you. Again, we always have to look at where the stone is, position of the stone, IV fluids and pain control, because nausea usually accompanies that severe pain, so they may get a little dehydrated. So treatment depends on, what was we said that, endoscopic, things like ureteroscopy, basketing, and laser lithotripsies. Also, percutaneous nephrolithotomy are treatment options that we utilize. As I mentioned, our guys will go just about anywhere with that ureteroscope and get a stone out. It's really changed, especially the flexible ureteroscopes. This is what a stone would look like if you were looking through the ureteroscope. There it is. That's what they see. And then they hit it with a laser beam, break it, and pull it down. Percutaneous nephrolithotomy, so either in the OR or by special procedures, a percutaneous tract through the kidney is accomplished. Remember, one of the ways that we get blunt trauma. Anyway, then the scope can be passed and bigger stones can be broken up and sucked out through the scope from above. Stone basketing, this is done to grab the stone and hold it. And of course, nowadays, they used to pull these out, but now they almost always laser them to make them smaller, unless it's a pretty small stone. And again, those small stones aren't getting treated too often because of tamsulosin. And that's what our little friend, the laser, looks like. It hits it with a beam, and it just kind of like shatters little pieces of it all over the place, easy enough to get out then, instead of a big stone trying to pull through the ureter. Shockwave lithotripsy, with or without a stent. The decision is made because of what? Whether you stent or not. Bless you. Size, right. So what happens is, in a shockwave, the stone is going to turn from a hard stone to powder. If you ever took sand and dumped it down a funnel, if you dump it slow enough, it'll go down the funnel. But if you do it like this, it may stop, because it's just too much for the ureter to handle. So the same thing, the stone coming down that tube may be too much and block it. It's something called a Steinstrasse, because how's that for my German? Because the equipment was invented in Germany, so they got to invent the name of a blocked kidney from broken stones. It means wall of stone in German. It's the only word I know in German. With or without a stent, so stent if it's going to be a big stone. Very minimally invasive, although we did talk about what can happen from shockwave. You can get a hematoma. So this was the very first shockwave machine. Anybody from Lutheran General, do they still have this machine? Do they? Yeah. A lot of the guys like it because they still feel it's the strongest machine. If it's a really big, hard stone, it'll break them, where the more modern, which I'll show you in a minute, doesn't always do. So there's our modern lithotripter. And Shockwave, as I said, likes to break up stones by changing them to small pieces, like we see here. Open surgery is rarely done anymore. But a metabolic evaluation is, if somebody's formed stones before, because you want to help prevent future stones. And the 24-hour urine will help us to find out our calcium oxalate, phosphate, uric acid supersaturates. Do they have any of these following problems? Because we can control some of, we can decrease calcium with drugs, oxalate, decrease in the diet, uric acid, we can change the pH. Low urine volume, people don't drink enough. Low citrate levels. Citrate prevents oxalate and calcium from binding. You can't take out calcium. You can't tell someone to go on a low calcium diet because we're loaded with calcium. We got bones. They're going to start breaking down your bones. So we put them through this 24-hour urine test, and they very nicely show us in the red the things we need to worry about and what we don't need to worry about. And then those can be adjusted and treated. And then it can be followed up to see if their adjustment has worked. Commonly, dehydration is one of the big ones. Again, we can change calcium with the diuretic, dietary changes, and leaving the calcium alone. Again, nursing concerns, we're going to want to watch for pain control, sepsis, hematuria, stent pain, anxiety. Yeah, we get a lot of nervous patients. And then talk to them about diet and fluid intake. So, since some of you are going to take the test now, because you feel so confident, when Thomas Edison was asked about how he failed to make the light bulb, he said, I never failed. He said, I just found 10,000 ways that don't work. So don't be afraid to fail the test. No fear of failure. If you don't get it right the first time, you can take it again. So knowledge is having the right answer. Intelligent is asking the right question. I will entertain any intelligent questions, or you guys are out of here. A big round of applause, and thank you. ChicagoMetroSUNA.org. Look at what we're doing. You'll like it.